Little. Good morning, everybody. Thank you for joining us for Winship Grand Rounds this morning. If you are an Emory University or healthcare employee and would like to receive a CME credit hour for attending, the access code today is 207393 and can be found in the chat feature at the bottom of your screen for our virtual attendees. If you've got any issues with this webinar or the CME login, please send Kadiatu Fofana an email or drop a note via the chat feature. This morning, we're pleased to welcome Dr. Erica Stringer-Reasor. Dr. Stringer-Reasor received her MD at the University of South Alabama. She completed her residency at Baptist Health System and her fellowship in medical oncology and hematology at the University of Chicago, where she was also trained in clinical pharmacology and pharmacogenomics. Dr. Stringer-Reasor is an associate professor in the Division of Hematology and Oncology at the University of Alabama at Birmingham. She is the director there of the breast cancer program, the vice chair for diversity, equity, inclusion for the Department of Medicine at UAB, and the chair of the Translational Breast Cancer Research Consortium Diversity Task Force. Her research interests include clinical trial design, pharmacokinetics and pharmacodynamics analyses, drug development, and of course, patient care. Her focus remains on translational research, specifically regarding the treatment of highly aggressive women's malignancies, including triple negative and HER2-positive breast cancer, as well as high-grade serous ovarian cancer. She's received grant funding from the American Society of Clinical Oncology, Susan G. Komen, the V Foundation, and the Breast Cancer Research Foundation. Under her leadership at UAB, approximately 26% of the patients enrolled in clinical trials are Black women, far greater than the national average of 3 to 5%. Please welcome Dr. Stringer-Reasor today for her talk, Current Treatment Options for Patients with HER2-positive metastatic breast.
Thank you so much, Dr. Kurthy, for that nice introduction, and to Dr. Kevin Kaplinski, who invited me, and you guys as division head. So I know this is really robust, a little bit early for us medical oncologists. We're still like having our first cup of coffee, but I appreciate each and every one of you guys that are sitting in the room or visiting via Zoom this morning. And today, I just want to go over some of the current treatment options for patients with HER2 metastatic breast cancer, because the treatment paradigms have certainly shifted over even the last 5 years. So here are my disclosures. So I'm born and raised in Alabama. I moved around like many of you guys during my training. So we are neighbors, and here's Alabama in the red. If you guys have not traveled to Birmingham, we're more central in Alabama. So please stop by when you travel to Tennessee or go down to Disneyland or Disney World, my bad, for Florida. Come visit us. So I just want to tell you a little bit about Birmingham. It got its name, and it's from actually iron ore, coal, and limestone mining. So it was home to many steel plants. It manufactured many railroads, and Sloss Furnace was established in the 1800s. It helped many of the citizens in the city of Birmingham make their living. Now, this is Dr. Torres' favorite statue here. This is Vulcan, which is the largest iron statue in the world. It's about 56 feet tall there, and sits really high, and it was a gift to Birmingham from Europe. And many of you guys know, especially as we come upon Black History Month this month, Birmingham was the home of the Civil Rights Movement. Rosa Parks made her name by boycotting the Montgomery buses. We also know about the bombing in the 16th Street Baptist Church where 4 little girls were attending church. It was a heinous crime by the Ku Klux Klan members at that time, and to encourage more segregation. And of course, Martin Luther King, known for his march from Selma to Montgomery in 1965, causing the Bloody Sunday. But all of this to say, this really helped Alabama embark on, achieving the Civil Rights Act of 1964 for all U.S. Citizens, outlawing discrimination. Is probably still today the largest bill in American history, signed by Lyndon B. Johnson. We also know about medical mistrust with the Tuskegee experiment, where over 600 African-American men between 1932 and 1972 were enrolled in a study for observation for untreated syphilis. And, of course, these were willing participants, trusting participants of the medical system. From this medical mistrust, gained the 1974 National Act to have informed consent. And this is something that we all do now with our IRBs. Unfortunately, no individual was ever prosecuted in this case, despite the large NAACP class action lawsuit. And just for a little bit Alabama trivia here, been notorious for our sports. You see Charles Barkley with basketball, Bo with football, Willie Mays for baseball. We also, Courtney Cox actually, and Tatum, also big actors there. And for singing, Lionel Richie, you see Nat King Cole there. And then Miss Jemison, who was the first African-American astronaut to go into space. And just like you guys, we have a little social media. You guys have Atlanta Housewives. We have Love and Marriage Huntsville there. And also known for our notorious beaches here, so in the state of Alabama. So just for some other facts, and you guys in Atlanta are very rich for diversity in populations in schools. We are home to 11 historically Black colleges, which is the most out of any state. And again, Atlanta is pretty robust in the city of, in you guys' city for having Morehouse and Clark and Spelman all sitting here in the city. And then everybody knows if you come to Birmingham, you have to choose. You got to choose a side between Auburn versus Alabama. So you're a Roll Tide or you're an Auburn Tiger there. You got to choose. All right, and then just a little bit about UAB. We were founded in 1945. We have over 1,000 beds. We're a level 1 trauma center, and we're in SAYA designated comprehensive cancer center associated with a medical school that enrolls 186 medical students a year. So that's a little bit about me in the state of Alabama. So I want to turn your attention now to our learning objectives with the current treatment paradigms of HER2-positive metastatic breast cancer. Again, because there have been so many FDA approvals over the last couple of years, figuring out the best way to optimize therapy for patients with systemic disease, as well as CNS disease, which tends to be a major problem that patients face once they have prolonged survival to HER2-targeted, prolonged survival in HER2 metastatic breast cancer. So there are many subtypes of breast cancer, as you guys know, and about 15% of breast cancer is overexpression of HER2 breast cancer, HER2 cells actually. And there are many targeted pathways, which include the extracellular pathways that the large monoclonal antibodies such as trastuzumab and pertuzumab do a good job at targeting. Also, the new antibody drug conjugate, these smart drugs, also do a really good job for extracellular blockade. And then more recently, those tyrosine kinase inhibitors also cause intracellular blockade of that HER2 pathway, causing apoptosis. So you can see here, since 1998, we went from monoclonal antibody, the first tyrosine kinase inhibitor, which was non-specific, to maybe about 5 years later, approving another monoclonal antibody. And then in 2013, to actually have the first antibody drug conjugate approved not only in the metastatic setting, but years later, even in the adjuvant setting to reduce the risk of recurrence. Again, the last approval for ADC was in 2022. So many, many strides over the last 20 years in HER2-positive breast cancer. So let's talk about the first-line therapy in HER2-positive breast cancer, which includes a chemotherapy backbone with dual HER2 blockade. And this actually originated from the Cleopatra study. And what we noticed that taxane plus trastuzumab improved progression-free survival, but adding another monoclonal antibody for dual blockade actually improved the progression-free survival to 18 months. And also the median overall survival was statistically significant as well. So keep in mind that 18-month progression-free survival as we talk about other therapies. Additionally, we found out that from the Federica study that subcutaneous Herceptin and pertuzumab also had equal efficacy. It was non-inferior to the intravenous formulation. And this is a good option for patients because now patients can come into the infusion center, get their subcutaneous injection, and shed off some time in the infusion center. We're not yet there where we can send patients home with the injections themselves, but maybe that's sometime in the future. And then as we think about second-line therapy for HER2-positive metastatic disease, we really focus on those ADCs, those HER2-directed antibody-drug conjugates. And let's focus our attention first on TDM1, which was our first antibody-drug conjugate that was genetically engineered to add this cytotoxic chemotherapy with this stable linker to the monoclonal antibody. So the chemotherapy agent was an anti-microtubule. The drug-antibody ratio was 3:1. But years later, we figured out a way to genetically engineer a better class antibody-drug conjugate, which had a drug-antibody ratio of 8:1, was able to have a tumor-selective cleavability linker. And with that said, some of the cytotoxic agents were released before hitting the target, causing the bystander effect. So tumor cells that overexpress HER2 or even HER2-low cells were also induced apoptosis if they were standing near the antibody-drug conjugate. So DESTINY-Breast03 was the first randomized study evaluating patients who had unresectable HER2-positive breast cancer who had previous treatment on trastuzumab. And these patients were randomized to a 1:1 ratio to TDM1 versus trastuzumab deruxtecan. And progression-free survival was the main endpoint. And we can see here, just like in Cleopatra, with the dual monoclonal antibodies plus the chemotherapy. Remember, I told you to keep in mind that 18 months progression-free survival. So in this, you can actually see a 28-month progression-free survival in trastuzumab deruxtecan compared to trastuzumab in Tamsine, which is TDM1, of almost 7 months. And so this also, also led to improvement in overall survival as well. Now, if we think about most common treatment-related toxicities in greater than 20% of patients, in the TDXD, patients tend to have more pancytopenia. And certainly you clinicians know that gastrointestinal disease tends to be more of an issue that you have to mitigate as well when patients are on these antibody-drug conjugates. Also, between the class of both of them, there can be some liver function increases in AST/ALT. Again, one of the rare side effects, but can be fatal side effects of TDXD is interstitial lung disease. So in DESTINY-Breast03, there were about 15% of patients that had pneumonitis or interstitial lung disease. And some of them, were grade 3, and we certainly know that this can lead to death. So really thinking about when you are evaluating these patients and treating these patients on trastuzumab deruxtecan, how can we detect this? Are you utilizing the 5 S rule. Are you screening for this? So asking the patient, are they feeling short of breath? Are you scanning? Are you every 8 to 12 weeks? Are you scanning the patient to look for signs of ILD in the CT scan, which would be a grade 1 toxicity asymptomatic patient? Are you suspending the treatment if patients are having early signs like grade 1 CT scans or having symptomatic disease? And certainly if they're symptomatic grade 2 or higher, really enforcing stopping the drug and starting steroids. So if you think about the evolution of progression-free survival after trastuzumab and taxane-based therapy in metastatic HER2-positive breast cancer, we've come a long way from 2006, where you were using a single-agent capecitabine initially to treat these patients, then adding a non-specific HER2 tyrosine kinase inhibitor, lapatinib, where we improved the PFS to 8.4 months. Then we go into adding the first antibody drug conjugate in 2012 with a 9.6 month progression-free survival, all the way up to 2022, where we utilized TDXD with a 28.8 month progression-free survival. So again, you know, lots of strides over the years to improve progression-free survival, which again ultimately has led to improvement in overall survival. So, you know, just thinking about what's next, there's a Destiny Breast 09 study looking at can we substitute or can we change or modify what the first line therapy is? You know, is chemotherapy plus HER2 blockade going to be the first line therapy, or should TDXD actually replace that? So this study looks at in a randomized fashion patients with untreated HER2 positive breast cancer, TDXD versus TDXD plus pertuzumab versus the now standard of care taxane plus HP. So how do we think about this in the third line setting for these patients with HER2 positive disease? So as we think about the journey of TDXD and how it got started, we think about this 184 patient trial in heavily pretreated patients that most of them had up to 6 lines of prior therapy, and they had overall response rates of over 60% with PFS of 16.4, which is, you know, pretty remarkable. And this led the investigators to think about, should we do this in a randomized fashion to change the standard of care, which previously TDM1 in the second line setting per the Amelia trial was the superior option. So in Destiny Breast 02, patients with metastatic HER2 positive breast cancer who had been previously treated with a taxane-based chemotherapy as well as TDM1 were randomized in a 2-to-1 fashion to TDXD versus treatment of physician's choice here. And on the left corner, you can see the improvement in progression-free survival in TDXD, again, which also led to an overall survival. So how do we think about in transition from these new smart drugs to these oral small tyrosine kinase inhibitors? Again, if we think about the first approved tyrosine kinase inhibitor, it blocked HER1 and HER2, and then we had a pan-HER2 blocker with neratinib there, but we certainly saw more side effects such as rash and diarrhea. And then we got a more selective tyrosine kinase inhibitor, tucatinib, which seemed to be more highly specific with less toxicities and even some CNS penetration. So as we begin thinking about these tyrosine kinase inhibitors, specifically neratinib plus capecitabine and the NALA study, which challenged the standard of care of lapatinib versus capecitabine, from a centrally confirmed database, there was an improvement in 2 months if you utilize the newer tyrosine kinase neratinib over lapatinib. This also showed a slight improvement in overall survival. Then we go over to the approval of tucatinib in the HER2 CLIMB study. And these patients, again, were pretty heavily pretreated. They had prior treatment with trastuzumab and pertuzumab, as well as TDM1. So if you guys were able to participate in this clinical trial, you may have noticed that it was really slow to enroll initially, just because patients had to have progressed on all three modalities. But once it started enrolling, it pretty much enrolled pretty quickly. So again, patients were randomized in a 2-to-1 fashion to tucatinib plus trastuzumab and capecitabine versus trastuzumab and capecitabine. And it's important to know that 49% of the patients did have CNS disease at baseline, and it was allowed if they were treated or untreated and asymptomatic, which this was one of the first of its kind to really allow patients with brain metastasis to enter. And so as you look at that progression-free survival on that Kaplan-Meier curve over to the left, you can see improvement with the triplet therapy compared to the doublet control. It's also correlated with improvement in overall survival. From this recently birthed the study of HER2CLIMB-2, and this was presented in San Antonio this past year, actually evaluating the antibody drug conjugate TDM1 plus the oral tyrosine kinase tucatinib versus TDM1 alone in patients who had prior progression on trastuzumab-based chemotherapy. Again, over 460 patients were enrolled with or without brain metastasis. And you can see an improvement in progression-free survival with the ADC and the oral tyrosine kinase of 9.5 months versus 7.4 months. You could also see an improvement in PFS when it comes to brain metastasis as well with the TDM1 tucatinib combination. Now, it's important to know that they did notice some more GI toxicities, such as diarrhea, abdominal pain, low appetite, some increases in the liver function test, and some thrombocytopenia in the doublet combination, which all appear to be manageable. So if we look at the first 2 lines of therapy to date, it still remains that we use dual HER2 targeted therapy plus a taxane partner. For the second line therapy, because of the improvement in progression-free survival, NCCN has gathered that to be a category 1 to utilize trastuzumab deruxtecan. So how do we treat patients with HER2-positive brain metastasis? So brain metastasis is becoming more challenging now. As patients are surviving longer, you know, some of our patients are surviving over a decade, when we used to say that overall survival in any subtype of breast cancer was about 20 to 25%. And so now these patients are living longer on this therapy, and these therapies are the tumor cells are actually escaping to the brain. And so what do we do? So the incidence of brain metastasis in the HER2-positive breast cancer is about 30%. There are even been some case studies that even say as high as 50%. And we know that the blood-brain barrier doesn't allow for exchange of much therapy to cross it. It actually even has an efflux pump on the endothelial lining that actually kicks out the drugs and cytotoxic agents. So it can be really tough to get a drug through the CNS, which often causes many industry sponsors to disqualify patients from studies with CNS disease because the drug may not cross the blood-brain barrier. Another rare but serious condition is leptomeningeal disease, and this happens in about 5 to 8% of patients. And again, this can be very challenging, and prognosis is often poor, with a survival of about 4 to 5 months. And that's even with intervention. So in a new era of treatment, you know, how do we think about selecting therapy for brain metastasis? Do we do systemic therapy first? Or do we do local therapy first? And, you know, I think this takes a really multidisciplinary team approach. You know, oftentimes if it's a single nodule that's bulky, say for instance, in the frontal lobe where patients are at higher risk for seizures, you know, that patient may be a candidate for surgery, especially if their cause is a mass shift. But in other cases where there are small lesions, even cerebellar lesions that may be treated well with SRS, that may be a good alternative for that patient too, to receive local therapy and not change their systemic therapy if they're on that. And then last but not least, we also have whole brain radiation therapy. And we try to think about sparing those patients this if we can, so that we avoid fatigue and other neurological potential side effects. So in the Cleopatra study, just kind of going back, to that first pivotal study in which we got dual HER2 blockade plus taxane-based therapy as our standard of care in first-line metastatic breast cancer. If we look at the two arms, there was really no difference between the patients that had a relapse in the brain or not, 13% versus 12%. But we did see that pertuzumab did decrease the chances of the brain metastasis appearing sooner. So dual HER2 blockade, if more efficacious in the body, tends to decrease the time to relapse in the brain. So if you look at this pooled analysis of Destiny Breast 01, 02, and 03, again, looking at TDXD for the treatment of metastatic HER2 positive breast cancer. And you break it down to the patients, which will be on the left, who had treated stable brain metastasis versus those who had untreated active brain metastasis. So again, our patients doing better if you don't treat them with localized radiation and give them systemic therapy versus if you treat them with radiation therapy and then give them TDXD, But I think one thing that is clear, that there's clear CNS benefit in either patient cohort. So whether they were treated or untreated, TDXD outperformed, physician's choice or the standard of care at that time. Also, you can see this effect in the Tuxedo study, where they looked at 15 patients who utilized TDXD every 3 weeks. And again, patients were either newly diagnosed untreated brain metastasis or had brain metastasis progression after exposure to local therapy with radiation or surgery. And so, again, you could see that overall response rates were pretty high among the cohort. Additionally, there was improvement in progression-free survival as well. Again, this is small numbers, but certainly patients had improvement in neurological symptoms and were doing better clinically. So taken all together, all the studies that have looked at TDXD for brain metastases, there's about a 60% overall response rate between all of the studies put together. So there's certainly a benefit in patients receiving TDXD, whether they had local radiation or surgery, or they were asymptomatic and no prior radiotherapy or surgery. So I think an interesting study that is actively accruing through the Hoosier Cancer Research Network is the Bridget study, and this is led by the PI, Sarah Sammons at Dana-Farber. But what you can see here, what about those patients that have stable extracranial disease but progress locally to the CNS? Can they roll into adding tucatinib plus trastuzumab, pertuzumab backbone, or would they do better in having better CNS progression-free survival by adding the antibody-drug conjugate TDM1 plus tucatinib? So hopefully soon the enrollment will complete and we'll know the answer to this. So next, let's think about the NALA study. Again, it was tyrosine kinase inhibitor, neratinib plus capecitabine. Again, there was the efficacy in the combination of neratinib over lapatinib, which was previously the standard of care. And this was both systemic and CNS benefit. There were a few patients that were enrolled that had leptomeningeal disease. They too also had some improvement in the progression-free survival. And then as we think about the more specific tyrosine kinase inhibitor, tucatinib, and the HER2 climb therapy, again, patients were pretty heavily pretreated and randomized to the triplet therapy plus versus trastuzumab and capecitabine. And here you can see the CNS benefit in progression-free survival. So patients that had stable brain metastasis, had a progression-free survival in the triplet therapy of 13.9 months versus 5.6 months. And then those who had active disease who were untreated had a lower progression-free survival, but still doubled the progression-free survival compared to just trastuzumab and capecitabine alone. Additionally, what's also interesting in the HER2CLIMB study is that patients who were continuing to have extracranial response, but unfortunately had CNS progression, were allowed to receive local radiotherapy. And in those patients, again, the triplet therapy, outperformed the trastuzumab capecitabine arm. And if they had a second progression, they too doubled their PFS as well on their triplet therapy. And again, all of this correlated to improvements in overall survival when you looked at the triplet therapy versus the doublet therapy. Now, some common side effects of the combination are hand-foot syndrome, diarrhea, decreased appetite, and some liver dysfunction. Again, this is dose dependent and it's easily manageable. So let's flip gears and talk about leptomeningeal disease. And so in the TBCRC, Dr. Murthy and I led the TBCRC 049 study, looking at the same HER2CLIMB regimen, specifically in patients with that rare but fatal leptomeningeal disease and HER2 positive breast cancer. And on this study, we did examine the CSF fluid, and all patients did agree to have an Meyer reservoir, and we were able to actually tell if they had circulating cells in their CSF as well as in their plasma, which was an interesting touch for this study. So the key eligibility are defined here. Radiographically, patients must have had MRI findings of leptomeningeal disease. Additionally, we did ask that patients have 3 neurological symptoms. So whether it's headache, vision loss, dizziness, etc. They also had to have some neurological symptoms to follow up with their MRI findings. We initially planned for a primary endpoint of overall survival with 30 patients, but during the COVID pandemic, patients didn't travel as much, and eventually tucatinib was FDA approved, and so we terminated the study early. And we found that did not compromise our efficacy data because many patients were having really great responses. So you can see here, when we diagnose patients with leptomeningeal disease, we don't always see that the CSF is positive. It may look equivocal, which gives us a hint of atypia, but there were certainly 35% of patients that had negative CNS and so didn't have frank carcinomatosis, but had dural metastasis not only in their brain, but also in their spine. You can see the numbers there. And most patients also had extracranial progression at the time that they entered into the study, with a median age of 53 years old, so a little bit younger. So what was interesting about tucatinib is that we knew there was detectable blood levels in the plasma, and we were able to detect those same detectable levels to an appreciable way also in their CSF fluid by tapping their Meyer reservoirs. And you could see at cycle 2, which was about 3 weeks, we could see that the tucatinib had reached steady state in the blood, and this was pretty equivalent in all patients. Additionally, the historical overall survival is about 4 to 5 months with treated leptomeningeal disease, and the median survival here that we noted had actually improved to actually 10 months, actually. So that you need to update this slide. So, this is pending submission to Nature Journal, crossing fingers that we'll hear something soon. So additionally, if you look at the patients that had responses, they started to have responses quickly, so we saw that after 2 cycles. So these patients were regularly imaged after every 6 weeks with MRIs of both the brain and the spine. And you can see here that patient had a frontal lobe lesion. You can also see the additional lesions noted intracranially. And when we get down to 6 weeks, you can see like the thickness in the left meninges in the frontal lobe is very thin. You don't see that. Additionally, the CNS or parenchymal lesions have dissolved, and it happened rather quickly. So it was amazing. One of our patients who had prior surgical resection and radiation that had terrible proptosis in the eye, within 6 weeks, we saw how well her lesions had dissolved and how improved her performance status was, where she was able to enroll with a performance status of 2 in a wheelchair and came back in 6 weeks walking into the clinic, and she was a young mom. So definitely touched me and did really well. Let's think about, treatment options for leptomeningeal disease. Certainly neurosurgery is on the table for those patients that have mass effect or hydrocephalus. Radiation therapy should highly be considered for patients with focal disease and definitely symptomatic disease to get them symptom relief sooner. We also think about intrathecal therapies or high-dose methotrexate for some of those patients. And how can we utilize these new systemic therapies such as tucatinib and TDXD that we know crosses the blood-brain barrier? So here are a couple of IT chemotherapies that are utilized in this space with solid tumors such as methotrexate and cytarabine, liposomal cytarabine. Often our heme colleagues utilize these regimens more proactively because the improvement is actually the responses are more robust. But certainly, for patients with frank carcinomatosis without any extracranial disease, this can be a consideration. There's been a smaller study of 16 patients with high-dose methotrexate that actually showed improvement in overall survival compared to the overall survival that you would see in patients that just have intrathecal delivery of the methotrexate. So I think what is hard in clinical practice is when we have to give IV methotrexate, we often have to admit them to the hospital. But with the COVID pandemic, many institutions are thinking about what inpatient regimens they can give patients as an outpatient. And so I know my center and many others are looking at IV methotrexate as an outpatient center, especially in some of these extended bed, hospitals now that we have specifically for our cancer center patients. So just thinking about intrathecal trastuzumab in HER2-positive metastatic breast cancer, specifically leptomeningeal disease, there's been a U.S. study evaluating this on a biweekly dosing basis for 4 weeks, and then less intense, larger dose weekly, then followed by an every 2-week dose, versus the French study that used a much higher dose of intrathecal trastuzumab of 150 milligrams weekly. Again, you did see an improvement in PFS and OS with both regimens. Again, small cohorts, but it's something that you can allow, afford to your patients. And then just thinking forward with neratinib again in leptomeningeal disease, there was a small cohort of 10 patients for compassionate use that also showed improvement in overall survival in the patients using this combination. And thinking about Dr. Elder and her work at Dana-Farber, looking at TDXD and leptomeningeal disease in breast cancer, again, seeing improvement in progression-free survival in this small cohort of patients. So there tends to be some response to the LMD when using TDXD. So the way I think about sequencing therapies in HER2-positive brain metastasis, again, when patients are diagnosed, still the first-line therapy remains a taxane plus the doublet monoclonal antibody. Second-line therapy, again, especially in treated stable disease, the preferred regimen is trastuzumab deruxtecan. We also know that that also works for patients who have active untreated disease, and certainly thinking about tucatinib, these oral tyrosine kinase inhibitors for second line or third line interchangeably. We certainly have TDM1 still on the table for patients in third line and beyond, which still remains a very good option for our patients, as well as other oral tyrosine kinase inhibitors, neratinib and lapatinib. So how do we navigate timing or targeted therapy when radiation to the brain is warranted? So this is, some new data that actually came out when we think about some of the studies that are actually using ADCs and overlapping modalities like radiation. So for instance, in the adjuvant Catherine study where patients had neoadjuvant chemotherapy and had residual disease after surgery, they went on to have TDM1 or a HER2 blocker such as trastuzumab. And what we found is that patients had more pulmonary toxicity when combining TDM1 plus radiation. So how do we think about that in the metastatic setting? Because we certainly have noticed that with utilizing TDM1 and TDXD, that there are more signs of radiation necrosis, pneumonitis, and skin toxicities when you overlap these treatment modalities. So as we move forward, and this goes on to all the targeted agents, but today's focus will be more so on the ADCs, as well as the small oral tyrosine kinase inhibitors. But if you look at the ADCs, TDM1 and TDXD, it actually has a long plasma half-life, and it takes about 35 days to remove all the drug from your bloodstream. And hence, that's why we kind of redose every 3 weeks. But you may want to consider delaying your redosing of your antibody drug conjugate if your patient is getting radiation for that fact that they're going to be at higher risk for radiation necrosis and potentially other things like pneumonitis. So in summary, leptomeningeal disease remains a high unmet need. There are current and limited data, especially on utilizing intrathecal data, but it's certainly useful in certain circumstances. And, these oral tyrosine kinase inhibitors and antibody drug conjugates are penetrating the CNS system and treating these parenchymal CNS disease, as well as treating the leptomeninges. And, just one local study thinking about treatment paradigms, if you're looking for novel therapy, my collaborator and I, Dr. Eddie Yang, are evaluating HER2-positive metastatic breast cancer who progressed on taxane and monoclonal antibody in the combination of niraparib and trastuzumab. And patients would stay on this until they progress or have intolerable toxicities. So what we found is that downstream internally, PARP inhibitors actually block NF-kappa B through a conical pathway, and it also stops the HER2 pathway from activation and causes cellular proliferation to cease. We found that HER2-positive breast cancers had high levels of PARP, both in the protein on a Western blot and in the DNA. We also saw this in ex vivo tissues in patient samples. And even in xenograft models, we also noted that patients whose tumors were trastuzumab resistant also had actually had less proliferation with niraparib in combination with trastuzumab. So this is an ongoing study. It's almost near completion. It was in the TBCRC. We have about 4 more patients to enroll. So if you got some patients that might be interested, send them to Birmingham. So final thoughts on this. Again, taxane-based therapies are first-line therapies, plus trastuzumab and pertuzumab in metastatic breast cancer. TDM1 still is the preferred second-line therapy because of the progression-free survival of about 28 months. Treatment for brain metastasis certainly varies between surgery, radiation, and changing systemic therapy. So really considering that multidisciplinary approach and team science. And then every step of the way, always consider a clinical trial when available. And thank you for your time. These are my 3 kids plus my bonus child, I guess. All right, thank you so much.
Okay. So we have some time for questions. While we're waiting for some questions to come through either the chat or in person, we just wanted to mention using the Q&A feature at the bottom of your screen. Also, there's no grand rounds next week. Grand rounds is going to resume the following week with critical updates in clinical research. And to view the lectures, please visit the grand rounds page on the Winship Cancer Center website or the Winship calendar. So, well, I have a question. Looking at all of the data around TDXD, and especially that pooled analysis from the Destiny trials, if you had a patient who presented with de novo metastatic disease and predominantly variant involvement, what would be your thought process about that first line of systemic therapy?
Yeah, I think, we're all waiting for all the studies to result from HER2CLIMB-02 and HER2CLIMB-04, because we really want to be able to utilize those antibody drug conjugates earlier. But the way that the guidelines are committed right now, even in patients that have brain dominant disease or symptomatic brain disease, the first line systemic therapy still remains taxane plus dual HER2 blocking therapy. So that's the textbook answer, and and then probably the insurance answer too, right?
Good point. Questions? Yeah.
So are you moving up your TDXD to the second line for the brain mets, or are you still using platinum?
Yeah. Yeah. So, I think that, if you look at the data in HER2CLIMB is remarkable because patients were heavily pretreated, right? And this was the first time that we actually saw patients actively being enrolled in a trial for systemic disease and brain, the CNS disease too. So with TDXD, we don't have as many the amount of patients dedicated for the brain metastasis, but the ones that we do, the CNS PFS is significant. And so, I would say today, TDXD is still perhaps a preferred over the oral tyrosine kinase inhibitor in that situation. Now, I have had some patients that wanted to delay, wanted to delay IV chemotherapy, and we're really happy with utilizing the oral therapies like tucatinib and capecitabine, and utilizing the subcutaneous injection for trastuzumab. And I think, for those patients, I think that that's still certainly reasonable for them to go that line as well.
I have another question. This last few slides you were sharing about the niraparib in combination with HER2, and thinking about that preclinical data about that overexpression of PARP in these patients. Your thoughts about us not using PARP inhibitors at all in patients who are HER2 positive that are germline carriers? Is that going to change?
Well, so, certainly, the paradigm is certainly changing. I mean, in our study with the PARP inhibitors, we did not allow for patients with HER2 positive disease to have germline mutations, BRCA1 or 2. We did, however, allow for them to have PALB2 mutations. That wasn't a key exclusion criteria. I think also as you look at some of the studies, you'll also see that some of the PARP inhibitors do have some CNS penetration as well. So in my study, again, I did not exclude patients that had brain metastasis as long as it was stable and treated. So albeit it will be a small cohort of patients, we'll certainly look at those patients in our study to see how their CNS disease is controlled.
I'm going to keep asking questions. When you were describing sort of the incidence of brain mets in patients who are HER2 positive or triple negative, your thoughts about us not routinely incorporating screening MRI in these patients who are presenting with earlier stage disease. But, you know, I think this is very practice specific.
It's very practice specific, but you know, I think with us being at tertiary comprehensive cancer centers, you know, we're certainly seeing those patients that are coming in here young, and there's, you know, stage 3 or 4, you know, when they come in, and those patients have a high risk of brain metastasis. And oftentimes, even if you have a frontal lobe lesion, right, I mean, it could be 3 or 4 centimeters, sometimes even 5, and patients are asymptomatic until they have a midline shift to have a seizure, right? And that can be very devastating. You know, cerebellar lesions tend to cause dizziness, and patients are unstable, have an unstable gait. And so they tend to be picked up earlier, but again, parietal temporal and frontal lobe lesions can really grow quickly and patients be asymptomatic. So in my practice, I am screening those patients with the MRI and taking a look at it. You know, if they have any kind of headache and didn't have history of migraines before, you know, I'm checking if their eye exam was fine, you know, or showed optic nerve edema, anything like that. I mean, I'm really having patients take that precaution and trying to diagnose those diseases early while they're asymptomatic.
Okay, I don't see any questions coming in through the chat. So if anyone here has any questions, otherwise, thank you so much
Thank you.
for joining us. Leave.